Dear chairs, dear colleagues, I would like to present my PhD topic, the novel treatment approaches in penile cancer. My name is Judit Vargha. I'm a urology and andrology specialist. I work at Semmelweis University in the Department of Urology. My mission is to search for a more effective treatment for advanced penile cancer patients and thus improve their life expectancy. We have 3 topics related to penile cancer. Each one I will present you in the next few minutes. Our first topic is comparing efficacy and safety of immunotherapy with chemotherapy in penile cancer patients, a systematic review and meta-analysis. As a background, I would like to highlight that penile cancer is a very rare and very aggressive disease. The first-line treatment after surgery is chemotherapy, but the 5-year survival is only 16%, even despite the chemotherapy, so we can say it's not enough effective treatment. Most of penile cancers are squamous cell carcinoma, which kind of carcinoma has been treated effectively and safely in dermatology. However, there is a lack of evidence to support its use in urology. So we aim to investigate the effectiveness of immunotherapy in penile cancer. Our question was, is immunotherapy more effective and safer than chemotherapy in penile cancer patients? We compared the efficacy and safety of immunotherapy and chemotherapy in penile cancer patients, and our hypothesis is immunotherapy is more effective and safe compared to chemotherapy, and the clinical implication of our study would be to introducing immunotherapy into daily practice for patients with penile cancer to improve quality of life and prolong their survival. We conduct a systematic search with our search key, which first domain contains the condition, penile cancer, whereas the second domain contains the therapeutic options, immunotherapy and chemotherapy. After the selection process, we found 58 articles in our topic. Before I present our results, I show you some interesting things we find with our first analysis. In this plot, you can see the overall survival probabilities, and we can see a huge gap between the studies. We figured out the 2 studies with better overall survival probabilities use immune checkpoint inhibitor therapy, mainly in first-line setting, whereas the 3 other studies use it in further line settings. So our first outcome is overall survival probabilities in immune checkpoint inhibitor therapy. We check this probability at 6, 12, and 18 months. We see decreasing survival probabilities, but in case of penile cancer, it's a promising result. Our second outcome is progression-free survival probability in immune checkpoint inhibitor therapy. We can see the same difference between the first-line and further-line studies, and we can see the same decreasing progression-free survival, and we only got the 9 months progression-free survival because the 1-year progression-free survival, we just have a few patients, so we can calculate them. When we collecting the articles, we realized that there is no article which compared immunotherapy with chemotherapy in the same article. So we collected chemotherapy results parallel with immune checkpoint inhibitor results, and in the end, we're planning an indirect comparison. So now we compare the results. In the 6, 12, and 18 months, we can see the overall survival probabilities. And if you check it, it looks like nearly the same. But the chemotherapy articles, every study use chemotherapy as a first line, adjuvant chemotherapy, and in the immune checkpoint inhibitor arm, we have further line settings. But we got the mainly first line immune checkpoint inhibitor study results, and in that case, it's promising. So the limitations of our study, we use single-arm retrospective studies, case serials, and case reports. We have a limited number of patients with very heterogeneous patients populations and treatment protocols. And the strengths of our study, this is the first systematic review and meta-analysis in the topic. Individual patients that are included in the analysis, and this is the largest patients population to date to investigating this therapy. We can conclude that immunotherapy for advanced or metastatic penile squamous cell carcinoma is an effective and safe treatment. And for daily practice, we advise consider immune checkpoint inhibitor therapy as a first-line therapy, especially combination with chemotherapy. And before the therapy, PDL screening is recommended. Or implication for research, we need more studies, more specific studies which compared immune checkpoint inhibitor and chemotherapy. PD-L1 expression have to be investigating because immune checkpoint inhibitor therapy is blocking PDL receptors. We are in the article writing phase. We nearly finished it, and our target journal is European Urology. Our second topic is investigating the effectiveness and safety of penile cancer, immunotherapy versus chemotherapy. This is an international survey. As I mentioned in the first topic, the novel treatment approaches in advanced or metastatic penile cancer is not enough effective. The survival is very poor. And in dermatology, with the same time of carcinoma, they use immune checkpoint inhibitor therapy as a first line with good results. In the European Urology Guideline, the immune checkpoint inhibitor therapy just mentioned with early evidence of promising clinical activity. So we aim to collecting patient data in immunotherapy where they get the immunotherapy as a first-line treatment. Our question is, immune checkpoint inhibitor therapy effective and safe in penile cancer as a first-line therapy? We were comparing immune checkpoint inhibitor therapy with chemotherapy in terms of survival and side effects. And our clinical implication would be to introducing immunotherapy as first-line treatment for penile cancer patients to improve quality of life and prolong survival. In our first study, we advised to further research to make more specific studies to compare these two therapies. So we started a study. It will be a retrospective data collection. We will collect chemotherapy and immunotherapy results, but only just the first-line treatment settings. And in the end, we will do a comprehensive matching analysis, and we will compare the different immune checkpoint inhibitor treatments, the combinations therapy with the gold standard chemotherapy, and we are searching for prognostic factors to realize which patient's population will benefit from this therapy. The ethical committee approved all study, and we just finished with the pilot phase. Our third topic is to investigate the reasons for prolonged denial in patients with penile cancer. This is a registry analysis. As a background, I would like to highlight the worldwide incidence of penile cancer has a very high range. In underdeveloped countries, it's much more higher. There's a few studies which shows the first medical examinations happens late when the tumor is already in advanced stage, and it's because the low social economical background and lower level of education. And we like to check the Hungarian status of these patients to identify the high-risk patients based on their social circumstances. So summarizing our topics, the first one we would like to submit in September, the second one in the next year, and we will start the third one in this year. And thank you for your attention. With a quote from Terry Pratchett, it doesn't stop being magic just because you know how it works. Thank you.
Thank you for your nice presentation. I would ask a question regarding to your second project, that what kind of immunotherapeutic agents would you like to investigate in your data collection?
Yes, thank you. So we will get two arms. One is the chemotherapy. We will collect just the novel guideline gold standard chemotherapy patients. And in the immune checkpoint inhibitor arm, every immune checkpoint inhibitor I know in dermatology there's only just the cemiplimab in the guideline, but in urology we use all the 9 or 10 immune checkpoint inhibitor.
Okay, thank you.
Thank you for your presentation. I would like to ask if this immunotherapy is used in Hungary currently.
Yes, we are started to use based on the dermatological findings. Every patient, we have to ask individual permission from the healthcare government, and we treated 9 patients with this agent.
Thank you.
I would like to ask you about the etiology of the penile cancer. Is the same like for the cervical cancer? Is there any way to screen it earlier or prevent?
Yes, usually before penile cancer appeared, there's a long period of chronic inflammation, some precancerous condition. So the patients have half year, sometimes 5-6 years to go to doctor.
And the HPV is also connected to the penile cancer, so I guess you see an increasing number now with the HPV shots?
Yes, yes. We have a subgroup analysis according to HPV. It's not really the infection, it's the HPV expression of the tumor tissue. So we think previously patients got HPV expression, but it's very interesting because in penile cancer, the HPV positive cancer is less aggressive than HPV negative. So these patients have a better chance to survive.
Thank you very much. Thank you for the great presentation. Sorry.
Thank you, Judit, for your presentation. Could you go back to the first Kaplan-Meier curve you had? So you mentioned there is the first 2 studies, they used the immune checkpoint inhibitor as the first-line treatment, and we could see a very clear difference between the other 3 studies, right? I'm asking about the purple line, like there is a sudden increased number of events and then it stabilized somehow. Did you find any explanation for it?
Yes, if the patients had a higher stage of disease, we can give any kind of therapy, they will die with this treatment. Usually the treatment looks like the patients come, we do some operation, after give some systemic therapy as operation, so it's a very hard therapy. And in this purple, in an article, they have much more higher cancer stage.
Yes, great.
What about the PD-L1 status of these patients? Was the treatment PD-L1 restricted? Could you do subgroup analysis based on the PD-L1?
Yes, thank you. We have a very few patients with known PDL expression, but we perform this subgroup analysis. And in this plot, you can see with PDL positivity, the patients have better chance to survive.
So positive means above 1 or 50?
Sorry?
Positive is above 1 or 50 in this scenario?
1 or 50?
What is the threshold for the PDL
yes,
to be positive
in
this
articles,
situation?
they just present it's positive or negative, so they don't present the percentage of the tissue which contain PDL.